is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
Good morning, everybody. This is Dr. Zach Baker of R2P and R2P Academy, and today's episode is one of our sports residency research article reviews. With all of these reviews, they follow whatever the theme of the month is that we're covering with our didactic material, both in the classroom and part of their independent study that they're doing as well. So this previous month, we covered the foot and ankle. And Abbey, do you mind just talking a little bit about the article that you selected?
So I chose an article that was about the acute Achilles tendon rupture and how surgeons go about repairing that. So it looked into open surgery, which is considered the gold standard for an Achilles tendon rupture, and comparing that to a percutaneous surgery where it's more arthroscopic in nature.
Nice. And I think Achilles ruptures are probably on everybody's top of mind, obviously with Aaron Rodgers going through his most recent speed bridge procedure, which drastically accelerated the timeline for returning to play or potential to return to play. This is not covering those techniques, but Achilles are something that are happening a little bit more frequently, or at least it seems so as we're watching, especially your higher level sports, probably a variety of reasons that go into that. But if you are a clinician in an outpatient sports setting, most likely you are going to encounter an Achilles rupture and repair at some point. And I think being mindful of the different types of procedures that are out there, and what we need to be mindful of in regards to precautions, postoperative rehab exercise considerations, and then ultimately what patient outcomes we can expect and how can we communicate that to patients. So, Abbey, can you talk a little bit about just what the trial design was, and really what was the makeup and the setup of this trial or of this study?
Yeah, so all these surgeries were performed by one singular surgeon, and it was a prospective study. The study kind of took place over about 2 decades, so like 2001 to 2018. This article is from 2001, and what they did is, depending on the time frame, the traditional open technique was performed within that first decade primarily, and then when you get into about the second decade of the study, they start to tease more into the percutaneous interventions as well. All of these patients were followed for at least a year post-surgery, and one of the big inclusion criteria is individuals that were included in this study had to have a mid-substance rupture, and the repair had to take place within 2 weeks of their initial injury. In addition to that, exclusion criteria-wise, anyone that had a prior Achilles surgery was excluded, in addition to those that sustained a double or triple rupture or involving the Achilles tendon insertion.
Cool. So we've got surgeries, 188 total. They range from 2001 to 2018. This study was published in 2021, so it's about 2-3 years back now. And in that first decade, it was really the traditional open technique was the more prevalent procedure. That was the one that the study focused on. 2012 to 2018, that's when they went to the percutaneous repair. And this is, you start to see the evolution of surgeries decade by decade as well. No different than how the ACL tears and those reconstructions and repairs have evolved. The methods with Achilles have also, and currently I have a few different Achilles repairs on my patient caseload. One is the open repair, one is the percutaneous repair. So even now you can still see some variability, and there's different, obviously, surgical considerations and clinical decision-making rules that are going to lend them to think that one is more or less appropriate for an individual. But be mindful that surgeries do evolve over time as we get better with surgical equipment, surgical technique, and just our overall understanding of them. But you still may encounter a variety of different techniques currently today. So with this study, what did they actually find in regards to outcomes?
So as far as outcomes go, the average return to sport or activity timeline was pretty similar. It averaged about 8.3 months for both groups. In addition to that, the big thing that they noted is the wound healing timeline and risk of infection was inherently lower with the percutaneous compared to the open traditional technique.
Cool. And then with these, did they talk at all about just some of the different metrics they were using? I know something that we typically utilize is like a single leg calf raise. It's a very good body weight strength metric. Did they get into ability to return to, we talk about return to sport, but what about returning to our prior level of competition or status with that sport? And that's something that you always see in the baseball community with upper extremity injuries. Hey, a pitcher following Tommy John or following rotator cuff or labrum repair, they may return to pitching, but they may have been somebody who threw 98 miles an hour and 200 innings a season prior to surgery at Major League Baseball level, and now they're throwing 92 miles an hour, maybe 50 innings, and they're down in single A ball. So there's a difference between returning to sport, and there's a difference between returning to sport at your prior level of function. Did they get into the weeds at all with some of that?
It didn't dive into that aspect too much. They did report that 65% approximately of the individuals in the study returned to their prior level of function. It didn't necessarily denote what level of competition that was at. And in addition to that, one of the limitations was that the population on average for males and females was about 40 to 42 years old. So it wasn't a ton of people that I was assuming were in super high level competition in their sport.
Cool. So we talk about patient outcomes and the potential differences between surgical techniques with regards to regaining range of motion, regaining strength, regaining prior level of activity. A big one that should also be top of mind and is really like front and center, especially in the early phases, has to do with complications. Did they notice anything in regards to either wound care or re-ruptures or skin integrity or things along those lines with potentially adverse reactions, not just focusing on the positive outcomes?
Yeah, this one was nice because it dived into those complications a little bit more than some other articles I had seen around the same topic. They reported 9.6% complications, so 18 individuals in the study experienced a complication. Throughout the study, there were 3 re-ruptures that occurred. One of those was with the open repair, and 2 of them were with the percutaneous repair. 2 individuals developed venous thromboembolism, and there were 13 suture reactions. These suture reactions, which could include infections, wound complications, or they require like the sutures to be excised, were all within that open surgery group and were not involved in the percutaneous group.
Cool. And then were there any significant limitations or shortcomings from this study that you found, and also any other just conclusions that you were able to draw from it?
Yeah, I think it was super helpful that all these surgeries were performed by a single surgeon, so you had a little bit of like standardization, but that's not really applicable to real world life. All patients you get with this sort of diagnosis aren't going to be from a singular surgeon. So I feel like in the future, it would be helpful maybe have a couple different surgeons that maybe like to do things a little bit different of a way and kind of dive into that a little bit more. And then in addition to that, there was a bias towards open procedures heavily in that first decade. Percutaneous wasn't really a thought then. So since the study spans 2 decades, all of the information I feel like was primarily biased towards that open procedure, which could have affected some of the outcomes that they grouped together as far as like complications. That wasn't necessarily applicable to one group versus the other. They kind of combined that as like the total number of individuals that were experiencing complications with surgery.
It's always nice when you have the single surgeon because then you at least know there's some sort of standardization in regards to what the patients are receiving. And you eliminate the bias, potentially surgeon experience or surgeon skill level, because it's all the same person doing the surgeries. Unfortunately, it may not always be the best representation of that actual surgical technique. And if it's widely used across regional areas or around the country by a variety of surgeons, you may miss out on some of that. And it may be skewed positively or negatively one way just based on how competent that individual surgeon is. With all of this information, what are some general takeaways or just application to clinical practice? So when you read this article, how is this going to influence moving forward your interactions with Achilles repair patients?
So obviously with all my new evaluations or any post-op patients, I'm always going to be adamant about checking incision sites, but I feel like this just goes to show, especially those with an open surgery technique, being a little bit more proactive with ensuring that there's no signs of infection, heavy on the education front with patients, just to ensure that these complications are mitigated as best as we can. Additionally, taking into account kind of the effects of surgery. So they mentioned some NFL players that had received the surgery, they're losing 50% of power in the gastroc complex. So taking that into account, especially as you get further down the line in the course of rehab and what you're going to aim to do in those later phases and kind of those smaller but still important things that you need to clean up in order to fully return individuals to their prior level of function and competition.
Absolutely. There are advantages to the open technique and there are advantages to the more arthroscopic technique. And a podiatrist actually relayed this to me one time when he's talking about foot and ankle injuries. And from a precautionary standpoint, with what you're looking at from wound healing or just potential complications, either superficially at the skin level or within whatever the structure was that they operated on, whether it be a bony injury, whether it be ligamentous, whether it be cartilage or muscle tendon. But he said you always need to be mindful of every time they go into that with their equipment, they're essentially altering the terrain of what's going on in there. Whether they're cutting through skin, connective tissue, fascia, whatever it may be, they're altering the terrain of what it used to look like and what it did now. More invasive procedures, an open procedure, there's much more terrain that's being altered, so there's much more potential for things to go sideways because of that. So it's just a general rule of thumb. I always think of surgeries as, are they taking something out or are they repairing something in there? And that kind of gives you an idea of, all right, if this is a meniscus repair and they went in and fixed and corrected and repaired viable tissue, that's going to have a significantly different set of postoperative precautions and considerations than a meniscectomy, where they're just removing the problem. It doesn't mean that one you can be more careless or more lenient with, but you just need to be mindful. Did they remove something or did they repair something in there? And that's going to dictate some of your postoperative precautions. But also, how did they access that? And are we looking at a multi-inch incision that they had to get to or just a few small portal holes to get there? And that may clue you in on how much early phase wound care, wound incision precautions you have. And then also being mindful with the different types of technique is there any variance in protocol? And this shows overall return to play timeframes were roughly comparable. But how we get to that time frame and what we're prioritizing maybe in those first 2 weeks, 4 weeks, 6 weeks, just based on some of the extra stuff that is going on, may influence how quickly can we bear weight, how quickly can we access different positions and different movements because we're allowing for incisions to heal. What are just universal precautions that we need to be mindful of with regards to weight bearing and strength training and mobility, and how is that going to influence our ability down the road to maximize force production and power. And I think early on, the thing that you notice with Achilles is if we are limited weight bearing or non-weight bearing, or when we can weight bear, we're through a restricted range and we're trying to allow this tendon to heal and the muscle to heal, force production is going to be limited. So we need to find ways to strategically target force production strategies early on, and BFR, blood flow restriction, utilization is a very, very effective way to mitigate that loss of strength, loss of or muscle atrophy that takes place. But then also being very intentional when we are allowed to start loading the joint and we are allowed to start stressing that tissue a little bit. How are we being intentional with regards to stance? How are we being intentional with regards to amount of load from a actual force production or volume of activity that we're asking them to do? And then through what range are we asking them to operate within? And those different variables and being very selective with which one and how many of them you're manipulating through the acute, subacute, later phase of rehab, that's going to pay dividends. And that's the difference between how well you do that early on. If that, they reference in here average of 8.3 months to return to play, it's really hard to play at 8 months if you're not doing sport-specific activity prior to that. And you can't do sport-specific activity if you're not doing running and general locomotive and plyometric corrections prior to that. You're not doing locomotive and plyo work if you don't have an adequate strength base preceding that. You can't do really efficient strength work if you don't have tolerance and mobility to work through prior to that. So you almost have to reverse engineer back to the beginning, and you start to realize, well, shoot, if we're not on the ball from day one, we may be causing unintended delays later on. Abbey, thank you for getting this article. Any other just closing thoughts or comments, or do we hit it all?
I think we pretty much hit it all.
Awesome. Well, Abbey, as always, thanks for doing the dirty work for us, and look forward to hearing your next article when we get into the hip next month.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.